Now I would like to invite the next speaker, Dr. Deepak Subramanian.
Thank you.
And he is going to speak on eTEP, groin hernia repair, techniques and advancements.
Okay, my talk will be on eTEP. So my talk will focus on port placements, various access options, and the key operating steps. Could you please change? It's not working. Yes, eTEP by definition is a concept developed by Hogge in 2009. It's a set of maneuvers and strategies undertaken to enhance a usable extraperitoneal space, which includes remote access, creation of large space, flexible port placements, division of its natural boundaries. Can you please change slide? Okay, it's working. Thank you. So we all know the importance of eTEP for ventral or incisional hernias because of the avoidance of composite meshes. But why eTEP for inguinals? It's because of the following reasons. For easy and fast creation of extraperitoneal space, for creation of a large surgical field, it's got better tolerance to pneumoperitoneum, better ergonomics. It's highly useful in cases where the distance is short from the umbilicus to pubis, in cases of previous pelvic surgeries, in complex cases like large inguinal scrotal, sliding or incarcerated hernias, especially useful in obese patients, post-bariatric patients. So if you compare the port placements of TAPP, in classical TAPP you go by midline ports. In the triangulation type, you place the ports laterally at equidistance from each other. But however, it has got its own limitations. In eTEP, you take a first camera port 5 centimeters lateral and 3 centimeters cephalad to the umbilicus. And the second port is at the level of lateral to the inferior epigastric vessels, and third port is at the level of umbilicus, and the hernia can be targeted. So in bilateral cases, first the larger side hernia is addressed first. And once the larger side hernia is addressed, you can either finish the other hernia with the same port placements with a little bit of difficulty, or you can add an extra port to address the opposite side as well, this way. Okay, moving on to the access options, there are basically 3 access options: the preperitoneal disposable balloons, the optical access, and the direct telescopic entry. We'll discuss one by one. The first one is the PDB balloons. It's easy and quick to perform. The hemostasis is achieved if balloon is left inflated for 3 to 5 minutes. By the time you enter in, the space is already created. Our problems are gas leak and it's expensive. This is a balloon insufflation video. You can see the initial incision is 5 centimeters lateral and 3 centimeters cephalad in a eTEP surgery. The skin is opened and the anterior sheath as well, and you can split the rectus abdominis muscle to visualize the glistening posterior sheath. So once that is seen, a little bit of finger dissection is aided, and the disposable balloon trocar can be directed towards the hernial site and inflated. So you can see the balloon inflation in process, and you can put the telescope in to visualize the space inside. And this is the external view of the preperitoneal balloon after inflation. And once you put on the scope, you can instantly see the Cooper's ligament, the inferior epigastric vessels, and on the floor you can see the peritoneum. Onto the roof you can see the rectus abdominis muscle. So a blunt trocar can be introduced and fixed. So next access option is the optical access. It's quick to perform, no gas leak here, but the technique is challenging and expertise is required. The chances of entering peritoneum is high if layers of the abdominal wall is not recognized and if angulation of the telescope is not done at the right time. So target sign holds the key. This is an optical access. You can see once you see the posterior sheath, that's the target sign there, and immediately you have to angulate the telescope parallel to the anterior abdominal wall. This is the same optical axis in an external view. See, you can change the axis once the target sign, and you can change the direction parallel to the anterior abdominal wall, and you can connect the gas tube. So So last option is the direct telescopic entry, which is cost effective, and the problems are bleeding control, and of course bursting suture is always required. So telescopic dissection, it is very simple. All you have to do is follow the white and you will be right, and forward and backward dissection only, no sideward movements, as you can open up the bleeders, and descend down till the Cooper's ligament. And once you see the Cooper's ligament, you stop and the space will be created. So arcuate light division, so is it a mandatory step or not? So after that, you'll be placing the second first working port lateral to the inferior epigastric vessels. You can see the vessels there. Once that is done, you move on, take your attention to the arcuate line. The arcuate line, sometimes you can proceed without dividing it, but most of the times you need to divide the arcuate line at least for 2 or 3 centimeters, or sometimes all the way till the level of umbilicus to place the next working port, that is immediately below the umbilicus. So once that is done, a needle can be placed, and the second working port can be placed. Okay, and the Retzius dissection is mandatory to do at least 2 to 3 centimeters of dissection in the Retzius, and it's always better to visualize the iliac vein. It's not necessary to skeletonize, but at least you have to visualize and to take down the preperitoneal fold of straddle, and until the vas deferens taking a turn over the iliacs. So Bogrove space is a key step in eTEP repairs. The key here is to stay close to the roof rather than onto the peritoneum or onto the floor. You have to stay close to the roof to avoid buttonholing the peritoneum. In eTEP especially, you need a little bit of more space to accommodate a larger size mesh. So this space, as you move superior and cephalad, you need to be really careful, because rent at this space, suturing is very difficult at this stage. So I picked up this particular video for indirect sac and pericalization of cord. You can see the triangulation of instruments in eTEP, the beauty about the ease of instruments handling, and you can instantly go down to the cord structures. You can take down the indirect sac from the vas deferens, and it's prudent that you don't touch the cord. Once that is done, sac can be reduced, separated, and it can be endolooped or sutured according to your convenience. So this is a large indirect sac with contents. eTEP can be safely performed in these kind of cases also. Here, once delineating the sac and knowing where the cord runs, you can open up the sac at some point and safely, and you can look for contents. You can see the content in this particular case is omentum. Okay, you can release those adhesions. And so once that is released, the remainder of sac can be circumferentially divided. The cord structures can be taken care of. And this is a big hole, so you need to suture this rent after parallelization. All right, I'm not going to show the suturing video. Right. This is an important step in eTEP surgery or in any inguinal laparoscopic surgery. You need tackling pseudo sacs. See, you need to tackle all the pseudo sacs and provide a good space for the mesh or landing zone for the mesh, and to avoid seromas as well. You can either tack the pseudo sac or you can take suturing. All you have to do is obliterate the defect and provide a good landing space for the mesh. Right. In eTEP, you can fix it with tackers or sutures, or if you have no fixation, not at all a problem. All you have to make sure is you create an adequate size, adequate space in the preperitoneal space, and instill a larger mesh so that the mesh doesn't move. If you place a smaller mesh and a larger space is created, you need to tack or suture the mesh. But if you create an adequate space and use a larger size mesh, you need not worry about fixation. So this is the buttock sign. You get it in large direct hernias wherein the reduced contents mimic the heel of a buttock. In large direct hernias, you need to pull the apex of this buttock towards you to different slippage of contents under the mesh. So always desufflate, resufflate and desufflate again to check the landing of the mesh. So I'm concluding with this slide. So this is the message from the great man. As long as your current minimal invasive technique allows you to establish the critical view of myopectoral orifice, you need not change it. However, learning the eTEP axis will open up a new world of surgical opportunities for the repair of inguinal, ventral, incisional and other extraperitoneal procedures. Thank you.
Thank you, Tarun.
So,
any questions, comments?
Thank you for this nice presentation. Thank you, Doctor. I'm asking about the distal sac. What do you do for it?
distal sac.
Yes.
Distal sac. Okay. Large distal sac can be abandoned. You need not go down to the level of deep ring, too much into the deep ring, and it will only cause bleeding. So at a safe zone where you have dissected or found a plane between the cord and sac, you can very well divide it safely and reduce it.
You don't face hydrocele or seroma post-op?
Pardon? I couldn't understand you.
Post-operatively.
Hydrocele, you don't see post-op hydrocele.
No, we don't do anything for the distal sac. We ligate or suture the proximal sac. You see hydroceles only when you do something for the proximal sac. Of course you have to, distal sac. Of course you have to make sure the hemostasis is perfect when you are releasing the distal sac into the scrotum. So
I see you cut the sac proximally and suture it
yes.
for the intraperitoneal opening.
Yes.
The distal left open and left.
Yes, just like that. It can be left open.
No hydrocele post-operative?
No, not at all.
There may be some seroma formation, but usually it absorbs.
And there is a technique where you split open the sac, distal sac, little bit to ensure that that doesn't happen as well.
Okay, thank you.
All right.
Thank you, Tarun.
Thank you, sir.